Hi, my name is Kelly Story, and this is going to be my week 1 lecture guide for mobility. And so for question 1, mobility is defined as, and it's going to be defined as the ability of body structure or segment to move so that range of motion for functional activity is allowed. The other definition is the ability of an individual to initiate, control, or sustain active movements of the body to perform motor tasks. Number 2 is going to ask about passive range of motion, passive mobility, active mobility, and passive mobility is dependent on soft tissue extensibility, whereas active mobility is going to be required neuromuscular activation in addition to soft tissue extensibility. Number 3 is going to talk about a question of hypomobility causes and hypomobility treatment. And so hypomobility causes is going to be due to prolonged immobility due to cast or orthotics or pain, inflammation, muscle tendon issues, vascular issues, and the treatment for hypomobility is going to be motor control or coordinating based techniques such as PNF, muscular isolation activities, movement pattern training, whereas hypomobility is going to be due to genetic, structural, or physiological changes, and the treatment for that is PNF, muscular strengthening. Number 4, questions of orthokinematics and osteokinematics motions. And so osteokinematics is going to be the physiological motions such as flexion, abduction, or in simple terms, just gross motor movements. Whereas the orthokinematic motion is going to be small scale movements that occurs between articular surface of the bone with synovial of a synovial joint. And this is going to be more of a glide, roll, or spin that is going to be produced during these small scaled movements. And so number 5 is going to be a picture of one or the other. So it looks like A is going to be a convex on concave surface. So that's going to have a posterior roll with an anterior slide following the concave convex roll. And B1 and B2 looks like it's going to be concave on a convex surface. So that's going to be a posterior roll and posterior slide following the concave convex roll. And number 7 looks like we're going into more some definitions. So the Golgi tendon organ response, which is going to be proprioceptors near a muscular tendinous junction that is sensitive to changes in tension of a muscle tendon. An example of this could be static stretching held for a period of time that triggers the stretch of the Golgi tendon organ that sends a signal to the spinal cord, causing the muscle to relax and allow it to lengthen. This is also going to be known as, particular to the antagonist only, known as autogenic inhibition, which is the next one, which is inhibitory effect on the level of the muscle tendon, tension of the muscle tendon unit. And so this is going to be particular if the stretch force is prolonged. So for example, for this one, it's going to be the contract relax. This stretch builds up tension in, let's say, the hamstring, causes the GTO to fire, sending a signal to the spinal cord and causing the muscle to relax. While in this case, because it is PNF, the clinician is going to passively stretch that individual, increasing range of motion. The next one is going to be reciprocal inhibition. And this is going to be the muscle spindle on the target muscle that's going to contract, which is going to cause that's going to cause the GTO to trigger on the opposing muscle. So for example, the quadriceps contract, causing the muscle spindles to sense that contraction, which is going to pull on the opposing hamstring tendon, which is going to cause a stretch. This is going to cause the muscle to send a GTO to respond to the spinal cord and lengthen, causing a more lengthening of the hamstrings. And the next one is going to be muscle spindle response. The muscle spindle is a sensory receptor that is detected in change in muscle length, rate of stress, and triggers the stretch reflex, also known as myotatic reflex, to resist further lengthening and protect the muscle from injury. A very good example of this is going to be the patella tendon reflex, where the doctor hits the bottom of the knee and the knee kicks out, and this is due to that myotatic reflex, due to the muscle trying to protect itself, sensing that quick change in length. The next one is going to be myotatic stretch reflex, which I just talked about, which is an involuntary muscle contraction that occurs in response to muscle being rapidly stretched. Again, very similar example of the doctor tapping on the patella tendon with the reflex hammer. Number 9 goes into, looks like static, all the different types of stretching. And so for this is going to be, let's say, static stretching. The characteristic is just going to be a muscle lengthening while in a stretch position held for a period of time. Dynamic stretching is going to be active controlled movement through available range of motion. That's progressively increases range of motion until end range is reached through repeated passive manner. Ballistic stretching is going to be a rapid, forceful, intermittent stretch that consists of high velocity and high intensity stretch through full range of motion. That's the last one. And then now we move into number 10, which is the differences in hold, relax, or different PNF techniques in general. Excuse me. And that's, so for the hold, relax is going to be a passive stretch that is followed by an isometric contraction, where the muscle doesn't move, the individual relaxes, and the passive stretch is initiated by the clinician. This is going to be due to the autogenic inhibition via the Golgi tension organ, which is activated, causing relaxation in that contracted muscle, allowing greater stretch. For the contract relax, the passive stretch is due to the isotonic contraction of the targeted muscle, followed by a relax, and then passive stretch is going to be repeated. This is going to be an autogenic inhibition triggered by tension during contraction. The contraction with movement facilitates greater muscle relaxation and stretch. And the following that is going to be the agonist contraction. This is going to be the passive stretch due to concentric contraction of the opposing muscle, hold and then relax. And then this is going to be due to reciprocal inhibition, which decreases the resistance of the target muscle by inhibiting via the spinal signaling and facilitating a stretch. All these stretches are going to be done by the clinician. And then for the hold, relax, contract, relax, and agonist contraction, this is just going to be the combination of the first two, hold, relax, and contract, relax, due to causing a passive stretch, isometric contraction, target contraction of the target muscle. It's going to concentric contraction of the opposing muscle, causing a stretch. This is going to trigger both autogenic inhibition as well as reciprocal inhibition, work synergistically to enhance stretch tolerance and range of motion. And then as we move on to number 11, which is asking why is it typically recommended to initiate joint mobilization in an open back position, and it's going to be recommended because of the joint capsule and the surrounding structures are looser in that position, allowing for the greatest possible joint play and movement with minimal resistance or compression. Number 12, it wants us to explain the key difference of nerve tensioners and versus sliders. And nerve tensioners elongate the nerve bed by simultaneously moving two joints in a way that stretches the nerve, increasing tension along the nerve path, whereas nerve sliders, it's going to move the nerve back and forth within the sheath by sequentially moving joints to glide rather than stretch that nerve. And then nerve sliders are typically more preferred as a treatment because it's less nerve tension and irritation, reducing symptoms and facilitating a safe neural mobilization, especially in the acute phase, without causing any excess strain. Number 13 asks, besides increasing range of motion, lists two other therapeutic benefits of performing joint mobilization. And the two other would be pain relief and improved joint function. Number 14, an athletic trainer is working to improve a patient's ankle dorsiflexion following the concave convex rules should they perform anterior posterior talar glide. And so for this, since the talus is going to be convex and the tibia is going to be concave, it's going to follow the convex concave rule, and the arthrokinematics is going to be more of the glide. So during dorsiflexion, the talus is going to roll anteriorly, so the glide should be posteriorly. And so therefore, the athletic trainer should perform a posterior talar glide to improve dorsiflexion range of motion. Number 15, the question is, describe a scenario where dynamic stretching would be more appropriate. Choice of the static stretching, and dynamic stretching is going to be a much better choice than static stretching because especially for athletes or just anyone wanting to be active, it's better prior to sport. Dynamic stretching is better prior to sport performance or training requiring explosive or ballistic motion, as it actively warms up the muscle, increases blood flow, and enhances muscular performance and reaction time as it mimics sport-specific movement patterns to prepare neuromuscular control and reduce injury risk. Static stretching, on the other hand, can temporarily reduce muscle strength and power, making it less suitable immediately before high-intensity activities. Number 16, what are two absolute contraindications for performing any range of motion exercises? And so two contraindications for performing any range of motion exercise, whether it be passive or active, is if there is a fracture or a joint location, inflammation, severe pain. These are all going to be contraindication of doing any kind of range of motion exercises. And number 17 is going to, an athlete presents with limited knee function during the evaluation. Passive and active range of motion to the knee are equally restricted based on the finding, what should we do? And so if, in this case, equal limitation of both active and passive of the joint is going to indicate more of like a joint capsule, joint restriction, could be due to adhesion, maybe even a bony block. Something is causing there to be some type of restriction from happening, preventing passive and active range of motion. And so number 18, explain the use or lose concept. And so the use or lose concept is a principle that refers of regular using or engaging joints and muscle to maintain mobility and flexibility through these interventions of just moving without continued movement, stretching, or exercises. These physiological adaptations, like improved tissue extensibility or neuromuscular control, is going to diminish over time. And then essentially to preserve benefits such as joint range of motion, muscle length, strength, and functional movement pattern, requires that individual to continuously be moving, to be using those ranges, those movement patterns, the range of motion, and so forth, or you kind of just over time lose it. That is my week 1 lecture guide on mobility.